Good morning, guys, and welcome to Chapter 9, Therapeutic Communication for Nursing 201. Today we are going to talk about all things encompassing how we speak with and relay messages to patients. So the objectives are going to be to describe the communication process, to identify two personal and two environmental factors that can interfere with communication. We're going to discuss differences between verbal and nonverbal, as well as talk about attending communication skills and how we can get the most out of our communication with our patients. So the communication process itself, the stimulus, is the need for information, comfort, or advice. So basically, you might see this as the basic human condition, right? And when patients are in the hospital, their need for comfort, information, and anything related to their care becomes even more important. And it can also be more difficult for the client depending on what's going on with them. The sender is the one who initiates contact. The message is what's sent or expressed. The channel is a variety of media, whether it be hearing, visual, touch, smell. In this case, we're using both hearing and visual because you're hearing my voice and taking notes, and it's visual through the slide process. Receiver is the person that interprets and responds through feedback. So what are some factors that affect communication? Can you think of a few personal factors that might affect how we communicate? One of the ones that comes to mind for me right away would be the difference between an introverted personality and an extroverted personality. Now, pretty logically, you can figure out who would be more talkative or more likely to send stimulus, right? Pretty much it's going to be the extrovert, yeah? So personal factors, how a person feels, how they're doing on that day, what their personality type is, what their culture is. All these things can affect how a person communicates. Some environmental factors might include whether or not it's noisy or there's a lot of background noise, whether or not a person feels that they're in a situation where their information will be overheard. When we're dealing with psychiatric patients, they're often discussing things that are very delicate in nature. They might be talking about suicidality or past trauma. In that case, they want to know that there's somewhere where that information isn't going to be kind of leaked around. When I think of environmental factors, I think of, say, a hospital ER. There are hospital ERs where there are only curtains between patients. There are other ones where they're full rooms with doors. So in that type of situation, or if you're in a situation where many hospitals oftentimes you have a roommate, you're not in a private room, right? That could definitely affect whether or not a patient decides that they want to communicate sensitive issues. Relationship factors is another factor that can affect communication. When you think about relationship factors, think about what you would tell your best friend versus what you would tell your mom versus what you would tell somebody in Cumberland Farms. Because if you think on that, it's usually very different, right? The type of relationship that you have with an individual, or if they're like a person in authority, or if they're a person that you feel is not someone you can trust. Those types of relationship factors are definitely going to affect how we communicate. So verbal communication. All the words a person speaks, their tone of voice, and their emphasis on certain words. The example that I always give is a patient approaching a nurse and asking if they can ask a question. Now, you can say the exact same thing, but the tone of voice and how we emphasize it can relay two very different messages. So if you say to the patient, "Sure, I'll be with you in a minute," versus, "Sure, I'll be with you in a minute." Exact same words, but the tone of voice conveyed the first time that somebody's interested in talking to their patient, and the second time that you're bothering the nurse, right? So we need to be mindful of these things. How we communicate also kind of extends our beliefs and our values, our perceptions and meanings. One of the things that we're running into is issues with social media. Oftentimes, somebody will place something on Facebook or someone might text something that without the full picture, without being able to see their face or see their eye contact or what their mood is, it may be misconstrued. An example of this is I had a patient who came in who was floating in their pool. They were happily pickled. They were drinking a beer. This is an adult, mind you. They're legally allowed to be floating in their pool drinking a beer. And they texted a friend that if so-and-so took over the company, then they were going to have to kill themselves other than work for that person again. Now, the perception and meaning behind the person was, I hate working for this person, and, just sarcastically, I will never work for this person again. The person receiving that message via text message, so verbal communication, but via the written word, visual, right, had a family member who had attempted suicide, or I believe completed suicide. So they immediately thought the person was serious and had the police pick them up. Right? So perceptions and meaning can change. Words can mean one thing to one person and not the same to someone else. We need to be careful because communication can convey interest and understanding. It can be insulting or judgmental. There may be clear messages or conflicting messages. And honestly, it could be honest feelings or it could be distorted feelings. What about nonverbal communication? We think about the importance of nonverbals when we talked about telepsychiatry. Someone can say to you that they're doing fine, right? Over the phone, they might be crying, they might be sullen, they might have their eyes downcast, right? You can't see their physical appearance. You won't know whether or not they had taken a shower. You won't know what their facial expressions are, what their body posture tells you, or amount of eye contact, or even the hand gestures. Maybe they're telling you over the phone that they're fine and they're flipping off the phone, right? Those nonverbal communications can really add a whole new dimension to what is being communicated, and they're extremely important in psychiatric medicine. So when we think about how we communicate, we've got to really look at those nonverbals. What are they telling us? Interaction of verbal and nonverbal basically is that messages can appear to be one thing when they're in fact something completely different. People are often less aware of their nonverbal messages and behaviors. You talk about people, they joke about RBF, people with a resting bleep face, right? We talk about that because that person may be super sweet. They might be very helpful. They might be very kind. But their nonverbal messages and behaviors are appearing to be one thing when even though they're actually a very nice individual, right? So there's an example of that. A verbal message is basically the content. The nonverbal message becomes the process, right? So we've got to look at both in order to really get the whole picture. Another thing that we need to keep in mind about is double-bind messages. This is a mutually contradictory message, usually given by a person in power. The example I love to give for this, and my mother hates it. When I was in school, and to this day, I am not very good at math. I can do dosage calculation till the cows come home, but don't ask me to do calculus because I'll probably crawl in a hole and cry. I remember taking course 1 Regents in New York State. And when I took the final, I got an 80. And I remember my mother saying to me, "Wow, you did really good. I can't believe you actually got an 80." Right? Mutual contradictory. She's telling me, "Wow, you did really well. Gee, I really thought you were stupid at math and not capable of that." Right? So that would be an example of a double bind message. So whenever you hear double bind, think of my mom. So next we're going to look at how do we enhance communication? How do we highlight effective communication? And what are techniques that can either obstruct communication or make them ineffective? So we want to look at both, what enhances it and what obstructs it. Tools for enhancing communication. One of the biggest things is the use of silence. Oftentimes when psychiatric patients are dealing with difficult content, it's hard for them to kind of come forward with that information. Giving them time to speak, giving them time to process is very important. So this is not only important when you're dealing with elderly population, because we talked about cognitive slowing, but it's also very important to be used in patients who are dealing with difficult situations or possibly with psychosis, which may lead to issues like psychosis will lead to issues like thought blocking. The use of active listening is equally important. Patients want to feel like they're being heard. So attending behaviors, looking at the person, nodding when it's appropriate, facing the person and showing interest is all part of active listening. And then we're going to discuss clarifying techniques. So clarifying techniques can involve a bunch of different things. One of the things that we talk about with clarifying is we talk about restating. So restating would be like, you think that your parents love your brother more than you. Reflecting, what you're telling me is your parents love your brother more. Exploring, tell me about how your parents feel about your brother. The use of open-ended questions is incredibly important. With an open-ended question, you're eliciting information and you're basically requiring them to expunge on what you're talking about. So one of the things I like, which is an open-ended question, and it's also an orientation question, when you're first meeting and developing rapport with a patient, you may say, "What brought you to the hospital?" That allows the patient to answer you in their own words, to tell you what their perception is of why they're there, right? Closed-ended questions have their place. There are certain questions that you really only need a yes or no answer, right? Could be, did you eat your breakfast this morning? Or have you taken your morning meds? Yes or no, right? So those are appropriate questions, but oftentimes we're trying to get in depth. We're trying to elicit more information, and that's why we want our open-ended questions. Another example of a clarifying technique is to use a miracle question. I always say, if you had a magic wand, or if your problem magically went away, or etc., right? These can be incredibly helpful. You put them in a position to say, if their world or their stressors were perfect and these things were taken away, do they feel it would be better for them? Oftentimes, that's a good way of addressing whether or not there are situational issues that need to be dealt with. Now, you'll notice it says, please see the handout in your clinical packets. In your clinical packets, which you will receive, there is a handout sheet. It's about 4 pages long, and it has lots of little boxes. And the little boxes are going to have time and sequence, formulating a plan, restating, reflecting, exploring, all those different types of clarifying techniques. And this is going to be very important. I'm going to use the test voice right now. You will need this for exam number 1. It is very important that you hang on to that handout. Make sure that you don't misplace it. When asking questions and eliciting patient responses, open-ended questions should always be your go-to. That's where you want to start your conversations. Asking questions like, what do you understand about your diagnosis? How can I help you? What needs do you feel you have? Can all be important questions to ask in any field, not just in psychiatry. Closed-ended questions like, can you rate your pain on a scale of 0 to 10? They're going to state a number, right? That is a closed-ended question, but that gives you information that you need to adequately control their pain. So they all have their place. Let's look at non-therapeutic communication techniques. The use of excessive questioning. Think of a toddler. Why is the sky blue? Because of the stratosphere. Why? Because we have a planet. Why? Because the sun reflects off of God knows what. Why? Right? There you go. Excessive questioning is annoying. When somebody doesn't want to talk, we have to accept that maybe at that time, that's not when we should be getting into those questions. It's okay for a patient to shut us down and say, I don't want to talk about that right now. Okay? Sometimes with difficult topics, excessive questioning is just going to push them away from you and not feel that you are someone who is therapeutic or someone that they can depend on. It is also not the nurse's job to give approval or disapproval. That is not our job. Don't be judgy, right? That is not the time nor the place. That is something that's appropriate with your friends. Like, I can't believe you just bought a BMW. Or like, dude, you just bought an Audi Q5. Giving approval or disapproval with your friends is fine. It is not okay with your patients. Also, nurses should not be giving advice. Now remember, it's one thing to say you may want to consider asking about going to a dietitian for help on recipes for your diabetes. That's not giving advice. That is evidence-based therapeutic care. It's another thing to say, well, I think you should go back to school because maybe if you got a better job, you wouldn't be stressed out. Can you see the difference between the two? So now let's look at verbal and nonverbal communication in cultural groups. We'll talk about communication style, eye contact, touch, and what happens when what problems can arise when nurses are insensitive to cultural influences. And, what does ICT do for us? What are some information communication technologies that can help us out? So first of all, cultural considerations. When we talk about different cultures, oftentimes there are different communication styles, right? Just look within the United States. You get people from New York City. And we talk a mile a minute, and we talk like this, and we're like, hey, what are you doing? Oh, I'm going out for pizza. I love pizza. We going to get a beer with that? Yeah, okay, great. Hanging out down in Brooklyn, doing what you got to do. Get on the metro. The damn MTA is not running again. I hate the MTA. I wish they'd do something about it, right? It's very fast. That's how we talk. Now go to Alabama. Are y'all going on Sunday? I think it's going to be a right good time, right? Both speaking English. One is particularly faster. One is a lot slower, right? But that's the communication style that is normal for that area of the country, okay? So communication style isn't only a cultural consideration in regards to like they come from France or they come from Nigeria or maybe they're Dominican. It can be right within our own country, and that needs to be accounted for because if you push too hard and too fast on someone, they may shut down. If you talk too slowly, someone who talks too fast may get frustrated. Okay, so you need to identify communication style within the patient. Eye contact is another big one. Think about eye contact. We like intermittent eye contact in the United States for the most part. You look at the person, then you might look away, and then you look at the person again. But what if you're Native American or Japanese? Intense eye contact is considered to be rude. When I used to work with the Native American populations up north and in Canada, oftentimes in interviews, they would stare at the floor, they would stare to the side of you, they would not make eye contact because it was considered rude to do so. Now, within psych, we oftentimes consider poor eye contact to be an indication of depression or that the person is lying to us or that there's something more going on. But with some cultures, that's just normal. An example I give about touch, and this story drives me crazy, is I worked with a doctor who was Hasidic Jewish. Now, in the Hasidic Jewish population, the only female that is supposed to be touching a man is his wife. The nurses that worked with this doctor used to oftentimes walk up and make physical contact with him, making him very uncomfortable, knowing full well that he was Hasidic Jewish. So touch needs to be thought about. When we talk about nursing, we often talk about the use of therapeutic touch. The other thing is, beyond cultural considerations, if you have a patient who's had trauma, physical touch can be frightening or anger-provoking. It's always best practice to just not go hands-on with our patients, okay? No hugging, they're going to be like, well, can I have a hug? Oftentimes we'll do like a fist bump or a handshake because that type of physical contact is not necessarily appropriate. And then cultural filters, forms of bias or prejudice. Now you can come up with 1,000,008 ways to Sunday where cultural and bias and prejudice exist. Not only racially, if you think about what people on the border towns may be going through in regards to Latino populations coming across the border. You may think about race and black versus white. You may think about Native Americans. You may think about all different biases and prejudices. Muslim populations, post 9/11, there's been a huge surge in bias and prejudice against those populations. So those are different things that you need to think about when you're engaging in an interview. So let's talk about the best setting and seating arrangements. How do we communicate during a nurse-patient interaction? And what are some attending behaviors that we can use to increase communication? So preparing for the clinical interview. The pace is the speed of the interview. If you go back to my example about Northerners versus Southerners, allow the patient to set the speed. Maybe there's thought blocking involved if they struggle with psychosis. Maybe they're talking about very difficult and sensitive topics. Let them choose how fast they move. Don't try to push, because if you push, they will shut down. One of the most important things about the setting is that it is confidential. If you're in a situation where a patient is agitated, which as a student you will never be placed in, you want to make sure environmentally that the setting is safe for the patient, but also for yourself. You will never allow the patient to get between you and the door. You may need to keep a door open so that other people can hear if anything escalates. From a seating perspective, you're going to want to get at the level of the patient. If you think about a patient lying in a bed, as medical nurses, we kind of loom over our patients, right? We stand at the computer, we're at the wow station next to them, we're talking to them, we're typing. How often do we actually sit down and get on their level? Unless maybe we're removing a saline lock, right? So seating is very important. You want to be arm's length plus their arm's length, ideally. You want to place yourself in a situation where it is safe. You want to sit at an angle. You don't want to be kind of boring down on top of them. If you're angled to them, it's less intimidating. You always want to make introductions. You want to come in, explain who you are, what your role is that day, and what basically is the anticipation of that interview. And when you initiate the interview, you want to be kind, compassionate. You want to listen to the patient. It's just like that old rule. You do not get a second chance to make a first impression. So when you're initiating the interview with the patient, showing that you're compassionate, showing that you care about their comfort, those can all be excellent icebreakers for that interview. Tactics to avoid. Do not argue with the patient. If a patient is not willing to give you information, if a patient is lying, if a patient is giving you a hard time, it's okay to stand up and go, right now you seem like you're not ready to talk about this, and that's okay. So I'm just going to give you some time. You can get up and walk out. That's all right. Never minimize or challenge the patient. Never give false reassurance. Everything's going to be okay. Well, do you know that? Do you know for sure that everything's going to be okay? Don't interpret or speculate. Use your clarification techniques. If you don't exactly understand what you're hearing, restate it. Allow them to state it again. We don't probe too hard into sensitive areas that a patient doesn't want to discuss. If they don't want to discuss it, that's their prerogative. In that particular situation, it's going to be more appropriate for the therapist or psychiatrist to probe those areas. As a nurse, if the patient says, I don't want to talk about it, we need to respect that. Don't try to sell the patient on accepting treatment. Well, the best thing about treatment is, right? You can talk to them about the benefits, but don't try to sell them on it. That's also not your place. And this goes without saying, do not join in attacks that patients launch on others, such as participation in criticizing other staff members. Psychiatric patients often engage in something called staff splitting, where they may see one staff member as being more helpful or more kind or more, insert the adjective here, than another staff member. It's far more appropriate to say, we're not going to talk about Jane right now. I want to talk to you about how you're feeling, right? So it may require some redirection. Attending behaviors include eye contact. Obviously, you don't want to glare at somebody. You're going to freak them out, right? So you want to think about your eye contact. It's okay to make intermittent eye contact with the person. Again, if you're constantly staring at your watch, the wall, or the clipboard you're writing on, patients may not necessarily feel that you're truly listening. Your body language, having a soft posture, keeping your hands in front of you. If you're dealing with a patient who is struggling with paranoia, perhaps they've had situations in the past with psychiatric medicine where they've been injected with medication over objection, and your hands are behind your back, that's not safe. Also, you don't want your hands to be in your pockets. That's also not safe. Heaven forbid that the patient should escalate. If your hands are in your pockets, it makes it harder to defend yourself. We talk about proxemics, which is the study of personal space, intimate distance. Think about when you're hugging someone or you're sitting next to your best friend and you're laughing and you stick your head on their shoulder, right? Personal distance with people you know is usually 18 to 40 inches. Social distance is 4 to 12 feet. That's usually, if you look around the room, you're going to notice that that's about the average for anybody sitting in the chairs today in the classroom. And then you have public distance. A public distance is wanting a bubble around you of 12 feet or more. Again, that can be situational. Depends on where you live. But if somebody doesn't know you well, it's more appropriate. If you think about the length of your arm plus the length of their arm, you've got at least a good 6 feet there or more, and then add a little bit more space. And a lot of times that's more appropriate. And again, your vocal quality. Sound like you're interested. If you're just sitting there going, yeah, versus, okay, that seems, I can understand why that must be very hard for you. Can you tell me more about, right? You know what an attending vocal quality sounds like versus boredom or you're just doing your job. And that's not what you want to convey. Now we're going to talk about the use of clinical supervision. And basically, these are your supervisors, your charge nurses. In your cases as students, it's going to be us as clinical staff. It's going to be Kristen, myself, Lauren, Clement. It's going to be all the people that are around you that can help you develop your skills, okay? This is incredibly important. None of us know it all. I still have patients that are difficult that I may go to the charge nurse. I may go to the doctor. I may go to the therapist working with that client. And I may say, what will help me work with this client? Especially if I haven't been on the unit in a few days. Just because I have 20 years of experience doesn't mean I know it all. Doesn't mean that I won't benefit from hearing from others that have worked with the client that may be able to give me communication and interviewing skills or icebreakers for that particular client. This helps foster professional growth. It helps minimize the development of non-therapeutic nurse-patient relationships, which ideally is what we want to avoid. Finally, you guys are going to be working on a tool called a process recording. What the process recording, and you do have examples on Blackboard, you also have them as part of your clinical worksheets. You're going to be doing those for all of us as clinical adjunct facility or faculty. You're going to be looking at what you say, what the patient says, what type of communication it is, and what the nonverbals look like. It's going to basically help you break down like your communication, just a basic conversation. It can be on just about anything, but really think about how does the patient look? If they discuss a difficult topic, do they look uncomfortable? Do they stare at the ground? How are they holding their hands? What are you seeing in regard to their feelings on top of what the actual message is that they're conveying? And this is a very useful tool for identifying communication patterns. Some patients struggle with communication more than others. Some nurses struggle with communication more than others, and it really needs to be explored. So, as a new nurse, you're assessing a client, and the nurse makes sure that the door remains open. What type of communication factor is that action? And I'm sure that you all rightfully picked A, environmental. And you'll work more on your communication skills as your clinicals progress, and you'll get a lot more confident and comfortable. All right, so case study. This is where the recording is going to end, because what you're going to do is you're going to work with Kristen or Clement, whoever's covering the class, on this case study. And I want you to think about what you're seeing, because Noah's your first patient, right? And he is depressed. He has fresh cuts on his wrist. His mother has had him admitted. While taking his pulse, you see that Noah also has a number of older scars on his arm. When he sees you looking at them, he shakes his head and whispers, "Yeah, well, it's just going to keep on happening." So Noah's whispered statement of, "Yeah, well, it's just going to keep on happening," does not involve which of the following? You picked feedback, right? We've got the channel and the stimulus. We certainly have a message, but we don't have feedback. The feedback would most likely be given by you back to Noah. So you prepare for the initial interview with 15-year-old Noah, and you learn that he has a history of cutting himself. His parents separated and are getting divorced. His father is left, and Noah's living with his mom. Noah has been smoking for about 1.5 years, and his mother suspects that he has come home smelling of marijuana twice. All 3 behaviors were ongoing before the father left. What are some communication and rapport building techniques that you as the nurse might use with Noah? Finally, Noah has made it clear he doesn't want to talk about his dad, but the truth is, as the interview proceeds, he becomes anxious and tries to evade all questions about why he's there. Which type of communication might be most appropriate? Now remember, A is not the correct answer, because we don't want to give advice. B is not the correct answer, because we don't want to give disapproving behaviors. If we did that, we could very well shut down communication. You certainly don't want to demand an answer as to why he is evading you. That would be inappropriate, right? So you'd want a D, ask a miracle question, and allow Noah to talk about whether or not, like, say, use the miracle question. Do you feel that you would be cutting yourself and feel this depressed if your parents got back together and weren't going to get a divorce? Does that make sense? All right. On to the next chapter.